edema, because there's an inflammatory process. So there's an inflammatory process, a sclerosis process. This situation is ideal for the endolift treatment. It is a tissue where there is an inflammation, even though it's a very slight inflammation. In this case, the patient, to solve completely her problem, has to undergo more than one treatment. The goal is to try and look for the filler, degrade it, reactivate the degradation metabolisms, because in this situation the filler is like encapsulated. Metabolism slows down until we have sort of a permanent. And then we have the fibrotic collagen, which is very reactive to the endolift, so we accelerate the metabolism of the filler. In this case, I will do the treatment without local anesthesia. We will check the setting. I will expect an edema that will last for a few days. We see that lymphatic drainage here is compromised, and the patient, which in this case is a colleague, is prepared and knows that for a week she will be swollen. When did she had the filler treatment? In May. So it's a very early inflammatory response. It was the first treatment? Yes. Did you do something in the past here? No. Never here. She did the zygomatic part? Okay. The hyaluronic acid. So the first treatment here was in May, and when did you have these tumescence? Immediately. Yes, so probably it's also due to hyper. So it got swollen and then it was reduced, but here's the bluish, reddish area. Started from the beginning. So probably an hypercorrection of this edema appeared. If it is an early edema, probably the quantity of product injected was excessive. We can access from 2 points. One here, from the zygomatic and malar part, to reach very well the area. And another axis here, above the malar, to reach the eyelid area. We will see how the tissues react, and we will modulate the treatment during the procedure. Any questions?
Sì, chiedono se ha fatto ialuronidasi.
Hyaluronidasis? No. Calcium hydroxyapatitis. If it were a hyaluronic acid filler, the first approach would be hyaluronidasis. I will use a 300 microns fiber. It depends also on your habits. Roberto prefers a 200 for the eyelid, but the choice is very personal. I think that each one of us should use what feels safer. With the 300, I feel safer. In this case, I would have used the 300 as well. So if she came During a different phase, would have you consider another treatment like cortisone? No, not here. In these situations of hypercorrection due to filler non-hyaluronic acid, since the very delicate area, cortisone, is less practical than the endolift. So I should say, maybe the results are not immediate, but we never had problems. So today it is my first choice in these situations. In other area where it is the first choice. Yes. Yes, definitely in these situations. There's one question. So there's a patient who underwent a permanent filler, which was then removed with a needle by another colleague, and she came here to ask for a consultation. I sent her to perform some tests, and I saw images of this filler around the edges of the orbits. What have you done? Can we use the endolift? Because I didn't touch the area. Well, rightly so. When you are not experienced enough, it is better to do nothing. So, if the residues of this permanent filler are somehow identifiable, touchable, palpable, you can go with a fiber, in that case a 200 fiber, focused on the lesion in case they are visible. Instead, if it's hardly palpable, but you have a precise idea of where they are, you can also do a random movement in the area, hoping to impact them, and with the tip of the fiber, you reach a more consistent tissue and you feel it. So when you explore the tissue with the fiber, you can identify the area where these small buildups are located. Recently, as I was saying before to Roberto and Bruno, I treated a lipofilling treatments with calcification, and the response was excellent. So the calcification disgregated under the laser effect. It's like the action of a popcorn on reverse. It was very suggestive. I'm afraid I did not film it. The advantage of endolift is that you have a high precision instrument. So when the build-up or the lesion is very small, you can identify it and go directly on it. Clearly, if you don't see it, you don't feel it, you can randomly treat the area, hoping to find it. In that case, what kind of settings do you use? On the area of the leads, I will show you now. Let's reset the tool. Let's go to custom. I will try 1.0 watts, pulse, T-on, 20, T-off, 75. 1.20/75. 1.5. are the volts that I use here, from 15 to 25 of T on, according to the thickness. Where I work here, there is an inflammatory tissue. I would like to be on the safe side. A few touches, and I will try to feel the tissue under my fingers and see if this palpable element that I feel under my fingertip, when I feel it more flat, more softer, I will stop. My endpoint here is the first appearance of a positive answer. Look at me. As I said at the beginning, I insert it between the two ligaments. The fiber goes here. Sometimes you want what? It's hard to go in. Look at the tip of my nose firmly. Look at me constantly. Never lower. Oh, it's the air. The air dries the eye. So look at me. It's important. I reach the area, you see? I am under the muscle. I feel the fiber where the tumescent area is. It's not a steady emission, it's just pulses. When I advance, I can avoid to do the pulse. I go a little bit towards the orbital malar ligament. You can feel it. So now I already feel a reduction of the thickness. I don't feel anymore the effect that I felt with the finger before. Before I could feel under the fingertips. Can you feel it? So the patient doesn't feel anymore that sort of thickness given by the filler. So I neatly, clearly feel the edge of the bone, while before it was not so clear. We can already see a collapse where there was a tumescence. Now you see, maybe you see better without the light. You see, the area collapsed. It's visible. If I try to expose the hypercorrection, in reality, I can see a little bit here again, but the medial part reduced its volume. How many joules? 4. See that the action of the tissues here are very sensitive. 4 joules. It's just a little bit. For a complete rejuvenation, I use 20-25, but here it's not a rejuvenation, it's a filler treatment, so it's a focused action. I say that in January she did some radiofrequency. Then probably in this situation could have created the inflammatory response. So I would like you to see the change. Can you see? This was the side where there was more tumescence. This is a perfect endpoint. I would stop here, I go and treat the other side.
Come dicevo prima, inutile e veramente, anzi, pericoloso cercare un
It's even harmful to try and find a resolution, immediate resolution. Maybe an immediate result, but not a resolution. Here it is more than visible and palpable. It's very good like this. Working on a tissue like hydroxyapatite, which is hard, I see whether the tip is altered, because when I used the fiber inside, it was like there was a sandy bed, a sandy tissue. So the same procedure on this side. Should we use ice in the treated area? Yes, we could use the ice, but at the end, once the treatment is finished, you usually put a mask, an ice mask. Sometimes here, if I see that there's an edema, this is not the case, I put 2 sterile strips to compress and invite the patient to keep them till the next morning. They work very well. The 2 strips, one horizontally and the other oblique. They have a good compression, they're practical, they are cheap, not expensive. So look at me. I go in from the same position. So we go in without emission of pulses. So first, so if you start immediately, maybe the patient moves. So 1 pulse, the patient feels it, gets relaxed, and he can start. We must always be careful in this area, also in case the patient moves abruptly. So again, the muscle here is more evident. The muscle here reacts to the laser stimulation. You can see the pulses of the laser. I have pain, okay, I know you're feeling pain. But it is more painful when you advance with the fiber and not when you pulse. Yes, it is true.
Ultimo passaggio.
Let's check the result. Completely disappeared. There's no more tumescence. You can see how the area collapsed. Yes, it could reappear because we have not eliminated completely the product. We have melted the fibrotic reaction. It's less homogeneous, less compact, so there's an immediate reduction in volume. But the problem is hardly completely eliminated. So you could have a recurrence. You could have again the area swollen due to the filler. I would monitor the patient. After a couple of weeks, in this case, maintaining a phone contact to see the follow-up, and in a couple of months, I would let the macrophages I would give them the time to eat away the residues, so they will help me more than any other element. And that's it. So the edema, immediate edema, is almost nihil. There's some erythema here. There's a drop of blood, but it's just a droplet. That's it. The treatment.
Scusa, 4 o 5?
Vedete che proprio anche guardi verso
Look up. So if we stretch the skin to check the presence of the product, it is completely flat and I cannot feel with my finger the product. Don't ask me why the result was so quick, but it works. So it's a clinical evidence. I'm happy. We rarely have this case of this kind of treatments. Can you see now how the tear trough is well defined? Well, the change was evident. It was very specific, but the outcome, I would say, exceeded expectations. Yes, I didn't expect such a brilliant resolution with a total emission of 10 joules. It's visible. The answer is perfect, and I'm happy to see that. But well, maybe because the device is brand new. The implant, the filler was there just for the last 5 months. If it were older, probably the response would have been different. Congrats to who selected the patient.
Riccardo.
So I have sterile strips. There's a question from the audience. And do you have any experience with silicone? Oh, great answer. Never under the palpebrae, the eyelids, but for the face and lips, great results. It's the go-to treatment today. I use the CO2 laser, vaporization, closure. So here, I use a truncular. What are the settings? Oh, the same settings. No. I'm sorry, I'm wrong. Setting for the phase 2.5 watts, 25 T on, and then the feeling, what you feel it under your fingers. Look up. Maybe you want to check the patient and the sterile strips will be applied later, because I think it's very interesting. I touched it before. I heard that it was very hard and firm.